Hello, everyone. My name is Melanie Escher, and I'm with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center, and welcome to today's program. So at the University of Arizona, we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So as you joined us today, your phone or your computer microphone were muted, and we are going to be using the chat function for questions. The chat function is down on the bottom of your screen. Um, and so please fill out the post-webinar evaluation that will pop up behind your Zoom window in a separate URL. And there's CME credit for attending this live presentation. The webinar is being recorded, but for internal and will be posted on our website. Um, and I will be sending out a thank you email. So you don't need to write down this URL. I will send it in a thank you email when we are done. So these are the continuing medical education, the outcome objectives, accreditation statement, disclosure statement. These were all on the flyer and when you registered, and I also sent it in my last email as an update. The University of Arizona does use the Cloud CME and has a attendance tracking for CMEs, and the information will be in my thank you email if you don't have a profile set up for that. We have a standard disclaimer. You can read that. And again, this is the Arizona Telemedicine Webinar Series, and please check our website for upcoming webinars and events. And that website will also be in my email to you all. And again, this is the URL for the evaluation, but I'll put it into the chat and it will be in the thank you email. I'm going to introduce you to Ernestine Nasingwaitua, and she is with the AIH AHEC. She's going to tell a little bit about that before we get started. Ernestine?
Thank you, Melanie. Hi, everyone. So yeah, welcome to today's webinar. The American Indian Health AHEC is grateful to the Arizona Telemedicine Program and the Southwest Telehealth Resource Center for this partnership. Today's presentation by Dr. Molina is going to be on maternal health, and I think that's just very crucial right now. So we've, worked really hard to, make sure that we got this information out as it, has a direct impact to the health in Arizona and communities. Just to give a short abbreviated summary about the American Indian Health AHEC. The American Indian Health Area Health Education Center is one of 6 area health education centers in Arizona. The American Indian Health AHEC works towards enhancing tribal healthcare systems and strengthening current workforce strategies and solutions. We do that through a variety of activities, including youth healthcare career exploration programs, community-based experiential training, AHEC scholars, community immersions, and events like today, continuing education for healthcare professionals. And yeah, thank you for joining us today.
Great, thank you very much. So without any further ado, I'm going to introduce our speaker today, which is Dr. Molina. So Dr. Molina, I'm going to go ahead and stop sharing this, and while you can bring up your slides, and I will read a little intro on you. So Dr. Molina is Pascua Yaqui and Yavapai Apache. He's a director of the Arizona Advisory Council on Indian Health Care. His interests are in the alignment of Indigenous medicine and Western medicine, and Indian healthcare law and policy. Dr. Molina has held positions as compliance officer and health systems director for Native Health Urban Indian Clinic in Phoenix, health systems director for the Kenai Indian tribe. Did I pronounce that correct?
Yeah.
Okay. In Kenai, Alaska, chief executive officer for the Phoenix Indian Medical Center and assistant director and medical director for the Arizona Health Care Cost Containment System, also known as ACCESS. He practiced as an OBGYN physician with the Indian Health Service and Las Fuentes Health Clinic and which he founded in his hometown of Guadalupe, Arizona, and he is also a U.S. Navy veteran. Thank you for your service, Dr. Molina, with that, among everything else that you've been doing. And if you wouldn't mind, go ahead and pull up your slides.
Okay, we'll go ahead and do that now. And I believe we're on.
And here we go. Dr. Molina, take it
Here we
away.
go. Well, thank you, Melanie, and thank you, Ernestine, for all you're doing, and thank you, Melanie, for your kind introductions. Yo Sanchamiavo and Molina Teak. I just greeted you in our Yaqui language, and thank you all for taking time this afternoon for this webinar. And I appreciate and honor the time that we have together here. Again, I'm John Molina. I am the director for the Arizona Advisory Council on Indian Healthcare, and which I'll give you a brief overview of in just a few minutes. Um, okay, let's see here. Okay, okay, here we go. I'd like to begin, and I usually begin every session with this quote that's been attributed to Socrates, that education is a kindling of a flame, not the filling of the vessel. And then I always try to encourage our participant to keep this in mind, that as we gain new information on various topics, it's not only an education we're receiving, but hopefully that this is ways that we can get inspired, have ideas into the work we're doing that can really begin to make a difference, because healthcare, as you know, is always evolving. And this evolution, I always believe, is a product of insight, of inspiration from what we learned around from each other and from our environment. Our objectives today are basically threefold. We're going to look at the factors driving disparities in maternal health. We'll look at key factors that impact Indigenous maternal health or Native American health, and also kind of wrap it up and start discussing some of the challenges and opportunities for improvement, looking specifically at Indigenous maternal health for the veterans. Before that, I'd like to give an overview of the Arizona Advisory Council on Indian Healthcare. It was established actually by Arizona Revised Statute a few decades ago. And in essence, this agency was created by the legislature to give tribal governments, tribal organizations, and urban Indian healthcare organizations in the state representation in shaping Medicaid and healthcare policies and laws that impact the populations they serve. And as we know, in Indian country, in underserved areas, that the Medicaid program is really an important aspect to healthcare. And we're just honored here at the agency that we can take part in being able to shape a lot of Medicaid and healthcare policies that impact the Indigenous people that we serve. Um, at this council, we also have an advisory board that represents the Arizona tribes. They serve in a advisory committee to give us direction, helping us develop a strategic plan as we move forward. In fact, we just developed a strategic plan for 2024 to 2027. Under this agency, the revised statutes also allow us as an agency to apply for and seek grant funding opportunities and to employ grant funded staff. And these grants allow us to expand the work that we do, going into such areas as disease prevention and health promotion activities, as well as training. Specifically, a lot of what we do is training in the ability for our tribal partners to be able to file claims and get reimbursements through Medicaid. Our mission statement is to serve as a resource for all tribal governments in the state of Arizona by supporting prevention, training, education, workforce development, policy, and legislation to meet the unique healthcare needs of American Indian Alaska Natives in Arizona. We also seek to educate and advocate for improved health outcomes. And our vision statement is to be recognized as a trusted resource on health equity for all tribal nations and American Indian Alaska Native communities throughout Arizona. And again, we really emphasize these two key words, supporting our tribal nations and also serving as a trusted resource in that we're an agency where our tribal communities, our partners who work with tribal communities can work with us in being able to address a lot of the health issues in Indian country. I'd like to begin, first of all, for just sort of giving an overall view in factors that drive disparities in maternal health. And many of you might have seen this slide or something similar to it, but I think it gives us an overview to sort of set the stage on how we're approaching maternal health care and some of the disparities and gaps and opportunities that be there. But I believe that so certainly that a lot of the what drives health outcomes in maternal care are really social and economic factors. This is something that I think we've all learned to see that such factors as economic stability, employment income, neighborhood physical environment, housing, transportation, um, education, level of literacy, language, level of education, food. Food is an important part that contributes to a lot of the health disparities we see. A lot of our nations are still suffering from food insecurity and healthy options because of distances where they live. And also the context of the community and the social context of where people live also is an important factor that drives a lot of the inequities in maternal health care. And certainly finally the healthcare system that is there to provide the care, the treatment, the follow-up is an important factor. So all of these factors really bundle up, drive what we're trying to address in Indian country, specifically in maternal health care. The other thing I want to turn the attention to is if you look at that line drawn going across those columns, we see racism and discrimination. You know, folks, unfortunately, through the hundreds of years that we've existed as a society, we still see elements of structural racism and discrimination. And I have to say, in my experience in clinical care, this continues to happen. And we make every effort to be able to drive this sort of, issue out of the population that we serve. But racism and discrimination is also something that really drives access to care. How comfortable a person feels in being able to access the healthcare system, the healthcare provider, because again, this is one of the areas that we continue to work with, and hopefully, as we move forward and become more educated, if you will, on this topic, we can make certain efforts like education and cultural competency and cultural humility. But certainly, as far as health outcomes, we're looking to improve mortality, morbidity rates. Unfortunately, here in Arizona, maternal morbidity was one of the highest among other states, where we're experiencing about 32 pregnancy-related deaths in 100,000 versus 20 nationwide. Now, I think COVID and has had a lot of impact in terms of what were the challenges and what were some opportunities that came out of this experience. And I just wanted to focus that with regard to maternal health, what we experience here, where our pregnant individuals, our patients were at higher risk of more severe symptoms than non-pregnant people. Some of this related a lot to anxiety and depression as a result of the fear of vertical transmission of the virus, limited accessibility to antenatal care resources, lack of social support, quarantine procedures that resulted in social distancing and isolation. And really what happened was postponement of many non-essential health services like prenatal care or antenatal care or reproductive care for young women. And as a result of COVID, we experienced a strained healthcare infrastructure. And as a result, we saw a lot of prenatal care visits decreased. The other part of it is that we found that women were more likely to lose their income than men, and working mothers really struggled to increase childcare demands. And this we sort of look at in retrospect to help look at not only the gaps that were presented here, but some of the opportunities that we find now going forward. And I know a lot of us have been involved in this planning post-COVID, that we can improve on some of these issues that came up in the event that we might have another COVID-associated or COVID-like pandemic. Now, I want to take a little bit of time that I think is always important to set the stage when we look at Indigenous healthcare, whether as a population or we really even focus on maternal healthcare or maternal healthcare for veterans, because as Indigenous people, we have experienced this, and it's a real-time experience. It's a real current time experience that we continue to have among our communities. And this is historical trauma. And this historical trauma, many of us have been educated on and we've learned about, and certainly our nations are making efforts to heal from this, if you will. But the definition of historical trauma is a cumulative, multi-generational, collective experience of emotional and psychological injury among tribal nations and their descendants going forward. Now, this historical trauma, was a result of European colonization. And again, we look at this not in a bad light, which unfortunately did cause a lot of impact on our Native people, but as a way to learn from it, as a way to be able to heal from it, as you will, to be able to recover from the effects of historical trauma. The events that happened during colonization really destroyed Indian nations, if you will. Um, the forced relocation of tribal nations. As you look at the map today, you see that most of tribes are west of the Mississippi, but most tribes existed all across the country. And this was because during colonization, our native people were pushed westward in what many call the Long Walk or the Trail of Tears. And as a result of this location, indigenous people were moved to distant lands that were unfamiliar for their hunting and their harvesting, or more important, their sacred lands that they worship. The other thing, being placed on reservations, which were basically military forts, and the reservations caused a sort of a forced reliance on the government. Genocide was the big one that wiped out the indigenous population. Before colonization, it's estimated over 200 million indigenous people lived on the northern continent. Today, there's only 2.7 million. These were the result of disease, wars, and massacres. Then finally, what really contributed a lot to what we see now is the abduction of youth, young children as young as 3, sent to more than 350 boarding schools, government funded across the country. This was a way for the government's way to, at least what they were thinking, was to civilize the Indian, to assimilate the Indian. But in reality, it was really to eradicate what they thought was the Indian problem. As a result of this boarding school experience, some experienced a good experience, others did not. Many of the children never made it home. Carlisle, which I visited a couple of years ago, the gravesite for the young children that never made it home were just grave sites with no names on them, unknown children that died at the boarding schools. You can imagine how forced relocation, genocide, and boarding schools made an impact on Indian people across the country, that now we continue to experience that cumulative multi-generational experience of psychological injury. But again, we talk about this in terms of when we work with Indian nations, we keep this in mind because of that experience that we live in. And, and when we think about it, when we gave the land acknowledgement, we understand that we were first people and we're living in a land that was essentially our land, but has now been colonized. Now, as a result of historical trauma, we see the after effects of this, and there's a lot of studies to show the impact on what causes historical trauma, generation after generation. Some of these are related to epigenetics, others are related to just the social environment, the teaching environment. That what we see now within our communities are the breakdown of traditional American Indian culture and language, alcohol and substance misuses, depression, anxiety, suicidality, child physical, sexual abuse and neglect, domestic violence, post-traumatic stress disorder, general loss of meaning and sense of hope, internalized oppression, self-hatred. And again, a lot of these factors that we just talked about then impacts health conditions and may increase the risk to obesity, diabetes, coronary heart disease, and cancer. Now, when we look at some of the key factors that impact indigenous maternal health and Native American maternal health in whole, there's some points here that I put up that I feel are important in understanding how these factors are impacting our maternal health. First of all, the Indian Health Service. The Indian Health Service created in 1955 as a way to provide healthcare to Native American people who qualified. Under Indian Health Services, able to provide pretty much inpatient, outpatient care in all different types of specialties. This was the government's way of providing healthcare to Indian people in turn for what happened during colonization, the millions of acres of land and resources that the government took over. In response was the government said, we'll create a system for you to have healthcare as a result of this trading of land and resources that happened. Now, some people like to call this free healthcare, but it's really not. Colleagues of mine call it a prepaid healthcare system. In other words, look at what Indian people gave up in order to have this healthcare. But unfortunately, Indian Health Service is not an entitlement program like Medicare or Medicaid. It's a discretionary program. In other words, every year Congress appropriates a certain amount of money for Indian health services. This year is $6.7 billion to cover healthcare services for Native people across the country. But unfortunately, it's still insufficient funding, which results in inadequate facilities, limited access to specialists, and really overall poor quality of care, which is still being experienced. One of the examples is the Phoenix Indian Medical Center. Phoenix Indian Medical Center was built in 1972 and is in awful need of a new healthcare facility. And it's been on the drawing boards for over 20 years, but because of lack of resources, Congress is not allocating that money. And we continue to fear for political changes, which continues that type of experience. Geographic barriers, remote areas, rural areas, tribal communities, and very outlying rural areas, access to their prenatal care appointments. And a lot of these access is not only because they don't have a car, but some of these places in northern Arizona, southern Arizona, the roads are just terrible. You know, they're dirt roads when it rains, when it snows, when it's muddy, very difficult to get across. So these are some of the barriers that we experience in providing care to Indigenous people in outlying areas. I talked about historical trauma. This historical trauma has also caused a mistrust towards state government programs or federal government programs. Can we really trust the government, even after experiences like the Havasupai experience, where blood was taken supposedly for diabetes research, but turned out they were doing other studies that the tribe did not agree on, or past policies like forced sterilization. In 1971, Indigenous women were sterilized without the consent. And again, add to that cultural assimilation, living in two worlds, trying to live in two worlds. There's a lot of mistrust in our Indigenous people in accessing care. Cultural competency is the other one. This, I hope, can reduce racism, discrimination. But there's a lot of lack of cultural sensitive healthcare providers being able to understand the culture and history of people, but not only understand it, but be able to validate and connect with people and being able to validate their cultural experiences, their cultural language, their cultural ceremonies, so that our patients feel validated and they don't develop this sense of mistrust. Finally, Medicaid expansion. This has been a great resource for Indigenous communities. As mentioned, 40 to 50% of healthcare is funded by the Indian Health Service, but the other 50% almost is funded by Medicaid. So a very important resource for our people. But still, some people, a lot of Indigenous people, because they just make a little bit too much to afford access. They can't be able to get that service, or maybe geographic limitations. They could be a Medicaid, but because of the locations far away in the different parts of the state, they're not able to access any specialty care. This is just an overview of the Indian Health Service system. And some of you may know this, but others, this is important to know because if you ever work within the Indian Health Service system, this will give you an idea for how it operates. First of all, the Indian Health Service system is made up of three different entities. There's the Indian Health Service facilities proper, much like the Phoenix Indian Medical Center, that is managed by the Indian Health Service, a federal entity. They usually consist of hospitals and clinic, but again, they're also funded at only 50% of need. And this Indian Health Service system is governed by 12 different regional offices across the country. We are in the Phoenix area, which oversees Arizona, Nevada, and Utah. Then there's tribally managed facilities. These are tribes that have contacted or contracted with the Indian Health Service to take over their hospital or clinic. And as a result, this has really proven to be a great move on Indian country because it really puts some management options on the tribe. And if you can imagine, there's no better entity to manage a tribal community than the tribe themselves. They understand their culture, the demographics, the people, the epidemiology of the community. So they're able to really provide a kind of care that really fits their community rather than having Indian Health Service provide the care. They've also been able to establish a different finance system, that they're able to increase their revenues through creating foundations, building partnerships with other profit organizations that the Indian Health Service can't do. It really increases the revenue. but they're also able to provide the same services through the Indian Health Service. Um, I'll talk a little bit about purchase and referred care. These are a different pot of money through the Indian Health Service that's available to Indian Health Service and tribal governments. And this is really money that's able to be expended for any member, enrolled member, tribal member, for any disease condition that might be life or limb, which can go into the thousands of dollars. So that pot of money is there. And finally, we have the urban Indian programs. There's one in Phoenix, one in Tucson, one in Flagstaff. They get about 1% of the Indian Health Service budget, which really kind of hurts them because over 70%, almost 70% of Indian people now live in urban areas, and urban Indian clinics are really struggling to meet the demands for healthcare. But they also provide healthcare, which could be comprehensive, limited. They also do a lot of outreach into the community. They do a lot of community-focused programs, wellness programs, a wide variety of services. So they have really been a great addition to the Indian population. For those people that come from the traditional Indian reservations, they come to a city like Phoenix to work for education and other things. Urban Indian Clinic really helps to meet their need. Now, having understood those three systems, this is what we call the ITU system. It's an acronym. It stands for I for Indian Health Service Manage, T for Tribally Manage, and U for the Urban Indian Clinic. Now, under the ITU system of care, that Indian family or the pregnant mom or the veteran, as long as they're an enrolled member of one of the 272 Native American tribes, they can access care to any of these facilities. Our Indian people are very mobile, so they happen to come down from Navajo to Phoenix and they need to be seen. They can be seen at the Urban Indian Clinic. But then they go back home, they can be seen at the IHS facility or the tribal facility, whichever is on their reservation, and they can go in between. They could go between all these different entities of care and still be able to be seen with no copay. Again, this goes back to the prepaid system of care for Indian people, as long as they're an enrolled member of a tribe. Now, if for some reason the ITU system cannot provide that level of care that they need, they venture to the right side, to the private healthcare system. There, Indian Health Service does not pay for that care. We're hoping that that family or that person would be either on Medicare, on Medicaid, private insurance, or their self-pay, because Indian Health Service won't cover it, except for purchase and referred care. Again, this is a special pot of money that the ITU system has that will pay for care outside of the IHS system if it meets the criteria of life and limb. So basically, one has to be under a deathbed in order for IHS to pay for the healthcare outside the IHS system into the private healthcare system. The unfortunate thing about purchase referred care monies, it's very limited to different areas, to like the Phoenix area, for the different hospitals in the Phoenix area, Arizona, Nevada, Utah. And that pot of money usually runs out by the fall. There's no money left. And one of the sayings around Indian country that if you're going to get really sick, and need hospital care outside the IHS, make sure and get sick before September, because sometimes after September, there's no money left. And unfortunately, that patient is left to kind of left on their own to figure it out. But then there's another pot of money called the Catastrophic Health Emergency Fund. This is for really big, high dollar hospital bills into the hundreds of thousands of dollars, which means a patient might have been in the hospital for weeks or for months. This has to be approved by the federal government in order to pay for that. So as you can see, although we have a great system of care that's prepaid, no copays, the services are limited. And this is always something to keep in mind, not to think that Indian Health Service can cover everything, but we really rely on our people to, if anything, get on Medicaid or maybe private insurance, because this would help. Even if you go to an Indian Health Service system, clinic, or hospital, you can still be seen there, even if you have private health care. My family and I have private insurance, but we still go to the Phoenix Indian Medical Center for our care because then the hospital can bill my private insurance and they get the reimbursement back. So it's kind of a win-win situation. Now I want to turn a little bit to our women, Indigenous women veterans. This year, in March of 2024, the VA Office of Women's Health had an honoring of Native American women who have served in the military going back to World War II. And currently, our Native American women veterans represent about just over 11% of all women veterans in the military. And I've seen that because as I've experienced and worked with different tribal communities, overall, Native American people has the highest per capita rate of recruitment and volunteering for military service overall. And what I get from people when we're asked, well, why would you want to join the military after everything that's happened through colonization, is because we're really, in a sense, protecting our indigenous land, our homelands before colonization, but we're also, honoring and protecting our country. So there's a lot of patriotism, indigenous patriotism, as well as American patriotism that goes into a lot of our indigenous people volunteering in the military. Women, especially a higher percentage of women, Native, are in the military than any other demographic or any other ethnic group. On the right-hand side there, you can see a picture, and some of you recognize your Loy Pastoa Hopi, was killed in action back in 2003 during the war in Iraq. And she was the first Indigenous women to be killed in action. And so we recognize her family, her nation, and her for her service. And by the way, as you may also know, what used to be called Squaw Peak here in Phoenix was changed under Governor Napolitano to Payasawa Peak. A lot of it, not only because to honor her, but also Squaw Peak was really not a good name. It was more discriminatory in sense, so we're glad we got that changed. Now, let's kind of move into looking at maternal health care, and then we'll kind of bring it into Indigenous maternal health care for veterans. First of all, the Indian Health Service System, the way it stands, and in most clinics, as you looked at the ITU system, really offers comprehensive services, but it kind of depends. It depends on the location. If it's a big metropolitan area, smaller town, a reservation, but in general, we do provide women's primary care, gynecologic examinations, family planning, contraceptive services, mammograms, ultrasounds, mental health care, behavioral health, also maternal health, prenatal education screening, specialty consults, referrals, also working with high-risk pregnancies, provide labor and delivery, postpartum care, and newborn care. I'll stop here a minute to just let you know that unfortunately, Phoenix Indian Medical Center, where I practice OBGYN, labor and delivery, about 3 or 4 years ago, closed down their labor and delivery site services. Unfortunately, it's because it's an Asian facility, couldn't keep up with accreditation, so they had to close it down. Again, this is one of the downfalls that we find with Indian Health Service funding. That hospital has been up for to be rebuilt 20 years, but still waiting. And unfortunately, the women there are now being referred to Valleywise, what used to be Maricopa Medical Center here in Phoenix. So the two hospitals are working together to provide prenatal care at Phoenix Indian Medical Center, but provide the delivery, patient care, and child care at Valleywise Hospital. Now, this might make sense to a lot of us that, okay, that's a great way to partner, and it really is. But unfortunately, what I find is that our Indigenous women who deliver babies, they really look forward to delivering it at Phoenix Indian Medical Center because they felt a sense of belonging. The majority of staff there are Native American. They're very attuned to Native American culture, the history, the people. They have a sense of cultural humility. and the women feel comfortable to have their ceremonies after delivery for the infant. Now, if you can imagine, that becomes a little bit more difficult in a non-Indigenous hospital like Valleywise. And so we're having to do some work with Valleywise to try to establish a sense of belonging for Indian people. Because when I was delivering babies at Phoenix Indian Medical Center 30 years ago, it was great to perform ceremony after the baby was born, perform ceremony postpartum, to have this available to our women, because to our Indigenous way of thinking, childbirth is sacred. And this is a way to bring the young spirit, the young life into the world. The other thing we do there also care coordination. Hospitals work with other healthcare facilities to be able to coordinate care and fill in the gaps of care. Now with the VA, we find the same thing with the VA hospital. Specifically, one I'm speaking to is the one here in Phoenix, which I'm also enrolled in. But when we look at Veterans Administration maternal health care, it's pretty much the same. They provide the wider services for women's primary care, family planning, contraceptives, reproductive care, mammograms, ultrasounds, lifestyle wellness, maternal health, education, screening. They also do genetic testing that's limited in the Indian Health Service. They do also consults for high-risk pregnancies. Now, in our women, our Native women, high-risk pregnancies are very common, especially related to hypertension, like preeclampsia, diabetes, gestational diabetes, and also because one of the factors that contributes to morbidity and mortality among maternal health care is mental health conditions and behavioral health conditions and substance abuse. These are big factors here in Arizona among our women in general who are pregnant that are risk factors towards morbidity and mortality. Again, coordination is also accomplished through the hospital with other facilities around the city. Now, this was an interesting development that goes back to 2010, where the Indian Health Service, the IHS, and VA collaborated to improve the health status of American Indian Alaska Native veterans. And I appreciate the VA hospital here in Phoenix for its recognition, especially during Native American Recognitions Month, to give honor and recognition to Native American the veterans. But in looking towards improving the health care for this group of population, in 2010, an MOU was created between the VA and IHS to establish a system of coordination, collaboration, and resource sharing between the VA and the Indian Health Service. Again, because a lot of our Indigenous people are veterans, and they're also enrolled with Indian Health Service, the system. Then in 2012, a reimbursement agreement was signed to financially compensate Indian Health Services for direct care provided to American Indian Alaska Native veterans who were part of the VA system. So for the Indian Health Service, this was another big step towards improving their financial stability and viability by being able to build a VA for services that they provided to VA enrolled Native American vets. So this was a big step and has proven very, very successful. So as a result of this, they're able to help fund inpatient hospital care, outpatient care, surgical care, and outside pharmacies. So it's really been a great way to collaborate. And this agreement, this memorandum of understanding, kind of serves now as a template for the VA to enter in similar partnerships and relationships with tribally managed facilities, part of the ITU system of care. Now, when we look at female veteran health issues, especially around maternal health care, things that we're faced with, again, are a lot of mental health issues. Now, this can be depressions, anxiety, post-traumatic stress disorder, again, not only from military service, but also from historical trauma that her family or community may have experienced, eating disorders, reproductive health issues that they have. So these are very significant. And I would say that when working with maternal, uh, Indigenous veterans, probably at the top of the list is to take this into consideration, to take a look at their history, their mental condition, to have time to engage with them, to speak with them. And I appreciate that, again, at this level of sort of engagement, that we need to have a good partnership with other health resources, social services, behavioral health, mental health, um, all the types of sort of integrative care system to be able to address these, because certainly our veteran Native women do experience a lot of this because, again, they're kind of living in two worlds, or maybe even three worlds: the indigenous world, the military world, and just the regular Western world. So being able to live without all these platforms of life can make it very difficult. Physical health issues among our women, uh, hypertension, elevated cholesterol, cancer. Our Native women, we have a high incidence of cervical cancer, liver cancer, stomach cancer, kidney cancer, and colorectal cancer. And these are all health issues that should be assessed in the beginning, uh, especially during the reproductive period. One of the things that I really work with my colleagues with Indigenous women, because they come in with a lot of physical and mental health conditions that may impact the pregnancy, is that even when they're in there for an annual exam, is to be able to get them as fit as possible in the event that they decide to have children. And this really goes into the primary care kind of care and looking at all factors of their health to, maybe address any type of social, mental health conditions that they might be having, to ensure that there's no evidence of other problems like hypertension. Cancer screening would be good. Diabetes runs very high in our communities, another thing to look at. And then there's spiritual and cultural isolation. When you're in the military, you're, with a different mindset, focused on the military. And many times there's a loss of belonging because a lot of our women, our Indigenous women, our veterans in military service, come in with a strong sense of culture and language and ceremony. And many times within the military setting is very difficult to be able to engage with. And this gives them a sense of isolation, spiritual isolation. And then that's finally, we've heard, evidence of different types of sexual harassment, assault, bullying within the military, discriminatory behavior, especially among women, Indigenous women. We think about the missing and murdered Indigenous women, Indigenous people, that is rampant across the country, the targeting of Indigenous women. And this could happen in all different areas of our world, and something, again, to very much keep in mind. So these for me are really the highlights of looking at maternal health for female veterans: mental health, physical issues, substance use disorders, spiritual isolation, and other issues that are kind of related to the social dynamics within the environment that they live in. So a lot of pressure, if you will, that I think our Indigenous military women and veterans are exposed to. So it takes a really caring team, an integrated team, to be able to work with them. Again, we're honoring their service because, as I said earlier, by far, the highest per capita rate of women, Indigenous women, that enlist in the military. Now, going to the last two slides here, in general, having been an OBGYN and the guidance that comes to American College of OBGYN, they've really established great guidelines for maternal health care. And I share some of these, which are, in general, just make a lot of sense. Meaningful, it says focus on integrated care services. First of all, meaningful access to care. And for me, meaningful doesn't just mean being able to get there, being able to get there in time, having transportation. Meaningful also means the ability to engage with that healthcare system. Engagement means how well does that patient trust the healthcare system, the healthcare provider? Because if the trust level is high, the person will make every effort to get to that appointment. If the trust level is low, the engagement will be low. So for me, this really drives a lot of what we're trying to establish in a healthcare system. Reduce discriminatory barriers, especially create a sense of cultural humility, cultural competence within our healthcare system. Take away these structural discrimination type of systems, then it becomes meaningful. Once there, you identify risk early, again, among our Indigenous women, our maternal women, veterans, have to look at their history because among our people, diabetes, hypertension runs high, colorectal cancer runs high. So these are things to address that could be potential impacts on pregnancies. Linkages to appropriate level of care, interdisciplinary, having an interdisciplinary team of not only providers, but social worker, mental health workers, behavioral health workers, people that help work, in employment, getting employment for them. Also, there's other issues. There might be some legal issues that that person might be experiencing, like having a place to stay, having been kicked out of their apartment. There's now a system, a medical legal system that is happens in a lot of facilities where there is actually services available for women and other people. Continuity and comprehensiveness of care, certainly. Training the social determinants of health, the first panel that we saw, the providers understand that every person that comes to them has a unique social determinants of health background, training in cultural humility, and promotion of efficient use of resources. I think that's critically important to make sure that we make the best use of what we have. And finally, these two last ones I put in there myself. One is to create functional partnerships with other facilities, non-Indian Health Service hospital systems like Honor Health, Banner, private practice groups, especially those specialized in high-risk pregnancies, like the prenatal associates or other groups that work to take care of these high-risk issues, and even academic healthcare centers, the universities. They have a lot of training programs. I found this to be as a way to be able to expand the resources that a tribal facility or an Indian Health Service facility might have in being able to access these comprehensive services of care for our veteran women, maternal health care. These are all needed because, as we shared earlier, not all the Indian Health Service facilities, the ITU systems, don't always have all the resources they need. So partnership development, functional partnership development is critically important. And I found that in the course of my experience over the years, that these partnerships are very much out there, and these organizations and private healthcare systems are very much willing to be engaged in doing what they can. I know, for instance, for our tribe, the San Carlos Apache tribe, the San Carlos Apache Healthcare Corporation, the hospital, now the tribe managers has been able to engage, just tremendously with a lot of other private care providers and academic institutions to provide high level of specialty care, specifically, for maternal health care. And then finally, as we noted a little bit earlier, the pandemic epidemic, the COVID pandemic epidemic, really opened up opportunities for telehealth services. And I think this is another area of medicine that has been developing over time. It's gotten better. And for sure, this is one of the other areas that I think when developing partnerships, especially with specialty care, we find that telehealth services can extend itself into these tribal communities, into these nations, and these areas that can really be able to enhance the care that our people can get, especially when dealing with maternal health care for veteran people. This is the last slide here I'm going to end with. Talking a little bit about the Native American perception of care, and I think it was best quoted by Cherokee Chief Wilma Mankiller, who's now passed on into the spirit world. And she was quoted as saying that her doctor did not know how to heal an illness, only how to cut it out. More search herself, she added, how he or her, the doctor, did not know my clan, my family, my history, how could the doctor know how to heal me? And for me, this code, especially when it comes down to uh, maternal health care for veterans, really emphasizes this element of developing trust with the healthcare system, developing trust so that engagement can take place. And this trust begins by developing a relationship with a patient. Like she says here, get to know the clan, the family, her history. Because among our Indigenous people, we're all about a kinship, relationship building. We know about each other. Many of our people, you'll find that when they introduce themselves in their native language and their relationship to the clan and to the family. This is important to us. It's critically important because it establishes who we are. And for Indian people, who we are is more important than what we do sometimes. Now, understandably, our Indigenous people do acknowledge and honor healthcare providers. But one thing that we look for is to get to know me as a person, get to know my clan, my family, my history. Let's talk about that, because then you begin to engage people, being able to then receive services and work with the provider, improve the level of compliance, if you will, and work with them. And again, for me, this is important for Indian people because that first slide where I showed the medicine wheel, it shows how we look at the world around us. We're also creatures of mind, spirit, body, and community. That's who we are as Indian people. And the more that non-Indian people are not familiar with Indian culture can see this, then it sort of sets a stage for how we approach people. In the area of Indigenous maternal health, this will make a huge difference in being able to provide that setting, that environment that will begin to establish that high level of care, the quality of care for Indian people, and hopefully reduce what we see in high levels of maternal morbidity and mortality. So with that, that is my last slide, and I just say Chiokwa, thank you. That's our Yaki for thank you. Another quote by Chief Sitting Bull, Papa Lakota, leader and healer. My wife is from Bomini, Pine Ridge, South Dakota. She's Lakota. And he says, let us put our minds together to see what we can build for our children. Another element of Native American culture is preparing our children, taking care of children, because they're a future generation. This gets us back to the sacredness of pregnancy and delivery, that our women see that as being a very sacred, important event, because that child is our future generation that'll sustain our culture and our people. So with that said, I thank you so much for your time. And Melanie, I'll hand it back to you for closing comments or questions.
Great. Thank you so much, Dr. Molina, for sharing that. We have some comments in the chat. Early on, when you were talking about the different losses, somebody made a comment of the loss of traditional birth keepers. And then they continued, supporting midwives doing out of hospital birth is also very important for ceremonial birth and maternal health access. She unfortunately wasn't able to stay for the whole, she had to leave soon, but she made some comments about that, and she looks forward to seeing the recording. Some people did ask about the recording. Yes, this is recorded, and the slides will be available on the recording later this afternoon. And let's see where else we got some questions in here. Accessing to the slides. Ernestine, did you have a question that you could ask Dr. Molina?
Sure. So one question is, what type of organizations are typically partners in comprehensive maternal health? Would that include CHRs?
The currently, I think within our IHS system and tribal communities, they do employ CHRs. They have been CHRs. That was have for quite a while. And I know that now we're looking at reimbursement for CHR activities, which will enhance the work of CHRs. Within the private sector, unfortunately, we don't see that. I think we only see that within the ITU system. And I know the urban Indian clinics, although historically they have not had CHRs, I think they're beginning to look at now this is another venue. But within the private healthcare system, I've not seen CHRs. They do might employ public health nurses, which is a whole different category. But as we know, CHRs are really know the pulse of the community, know the people, know the culture, know the language, and they're probably the most influential in helping our people get engaged with healthcare services. They were essential during the COVID pandemic because they were able to outreach and be out in the community. But we hope that as time goes on, that CHR will be employed in much bigger numbers. Yeah.
You. We have another question. How do you see the role of men in addressing maternal health disparities and supporting Indigenous women throughout the maternal health care process?
Well, I think for the most part, most providers are still men, especially maybe not so much, but it used to be within the OBGYN field. But I think for me, what I would give as far as any sort of thoughts towards that question is get to know as much as you can about the community and the culture that you're working with. This is very important because it's part of establishing not only that cultural competence, but the cultural humility to be able to see it from their eyes. And then it becomes especially important if there's certain taboos that relate between the relationships of women and men. So the more that you understand and get to learn from that patient, the more it'll help you navigate to the work that you have to do regarding your standard of practice. Because there are certain things that we have to be mindful for, especially when there's conversation between women and men who are not related, that maybe men might need to be cognizant of. And the only way you'll find it out is get to know more about the culture, the people, the community, their ceremonies, and some of the nuances that they have within that community. What's helped me a lot is that if you happen to know of maybe another Indigenous woman that's part of your facility organization or works in the healthcare field, ask them how can I best relate, to this person, and that's another way that might be helpful.
That's very sound advice. Be direct communication is usually your best bet, right? Great. I don't see any other questions right now. But again, thank you very much, Dr. Molina and Ernestine, for helping put together our maternal health series. We had one last week as well. This is recorded and we will have the slides up on our website. I'll be sending a thank you note to everybody with all that information and how to get your CMEs for our physicians that are online, or if you'd like just a certificate of participation. Again, so we are right on schedule. If there's any other questions, go ahead and put them in the chat real quick. We got 2 minutes. And I see there's quite a few names that I have recognized. So thank you again for joining us to this webinar as well. I don't see anything more. So we're going to go ahead and we're going to call it a day. Ernestine, did you have anything else to say? Do we have any upcoming topics? We'll be working for our 2025 schedule.
Yep, we
Right?
are working on our 2025 schedule, rounding up speakers, feature presenters. So yeah, we'll have definitely more webinars in the 2025 year. So thank you everyone
Ex
for attending.
Excellent. Thank you very much. And again, Dr. Molina, thank you for joining us and sharing your insights and your expertise. And thank you for your service again. And thank you, everybody. We'll see you on our next webinar. Take care, everyone.